risk, in high risk, as well as very high risk. And here you can see in low risk, based on the management also, if we can have an option of active surveillance. In high risk, intermediate risk, or high risk, or locally advanced, the management is totally different. We don't have an option of active surveillance. And a small slide on risk stratification metastatic thing. There are two things like oligometastatic or low volume metastatic or high volume metastatic based on charted or latitude. Here you can see if there are more than 4 bone mets, including more than one outside vertebral column or pelvis, or if there are visceral mets, we can directly take it as high volume mets. So here also risk stratification is important. Coming to the take home message, the risk stratification is the cornerstone and it guides management, and we should start metastatic workup from intermediate unfavorable risk irrespective of AU or NCCN. Most of the urologists, we follow AU. And the Gleason grade and PSA are the most important prognostic factors. As the high PSA increases, as the Gleason grade increases, that as the advanced stage increases, there is more chance for biochemical recurrence as well as regional metastasis or distant metastasis in future. The goal of risk stratification is the precision treatment, the right therapy for the right patient at the right time. For low risk, you can observe more and treat less. For high risk, you should intensify the treatment as early as possible. Thank you.
Thank you. Thank you, Ravi. Nice presentation. Ravi Mohan and Deepak, brief comments.
So easily summarized that of risk we should know you can treat aggressively. That's only for counseling or patients. In day-to-day practice, you have all sorts of mixture of risk stratification with patient psychological turmoil of having a cancer, which comes into play, and majority would end up low intermediate would end up with radical prostate, and high risk would end up with radiotherapy ADT. But yes, very nicely summarized that identifying risk stratification helps you to tell the patient what are we like, what is he likely to expect in future. So it's very essential to know the stratifications.
Yeah, second.
Thank you, sir.
Nicely presented.
Ravi Mohan, do you use any software to put the data routinely, or in only selected patients you use those softwares?
Only in selected patient. Otherwise, mostly.
Otherwise, clinical assessment is fair enough.
Yes, clinical
Based
assessment.
on these parameters which he has mentioned.
Yeah, almost holds true.
Yeah. Deepak, anything you want to comment?
Yeah, nothing.
Okay. We'll go to the next speaker. Active surveillance and focal therapy, current evidence. Dr. Amresh Mohan from Hyderabad. Amresh is consultant uro-oncologist at Basavatarakam Indo-American Cancer Hospital and Research Institute. Amresh, please wait. I am reading it. I am reading your CV only. Previous worked as urologist at Delta Hospitals, Rajahmundry. Completed MCH Urology from KMC Manipal. Fellowship in Uro-Oncology and Robotic Surgery at Basavatarakam Cancer Hospital. Is a intuitive certified robotic surgeon. Areas of interest are endourology, uro-oncology, robotic and reconstructive surgery. Now over to you. Thank you.
I think, Amresh, you are able to upload your slides.
Yeah. Is my screen visible?
It's visible. Now it is a full screen. Yeah.
Yeah, thank you. I thank Chandramohan sir and Deepak Kaddu for this opportunity. So,
yeah, welcome.
So what is active surveillance? It is a structured, evidence-based management strategy for men with low risk or selected favorable intermediate risk localized prostate cancer, in which the intention is to delay or avoid curative treatment, that is surgery and radiation, until there is clear evidence of disease progression. So it uses regular protocol-driven monitoring with serial PSA testing, DRE, multiparametric MRI, and interval repeat biopsies, and offer timely curative treatment if reclassification occurs. So what is the need for active surveillance? So because it has proven to avoid in indolent prostate cancer, and in the 15-year PROTECT large randomized controlled trial results, it has shown there is no difference in prostate cancer specific mortality across all the three groups of active surveillance, radiation, and radical prostatectomy. And also active surveillance shows very low risk of metastasis as well as mortality. And most importantly, the quality of life is preserved in up to 50% of these individuals and who remain untreated at 10 years. So that is the reason active surveillance utilization is rising worldwide. In US, it has been adopted almost 27% and it is risen up to 60% in the current era. So who are the ideal candidates for active surveillance? So as per the EAU guidelines, active surveillance is the standard of care for low risk patients, that is Gleason grade group 1 with the PSA less than 10 and low PSA density and low volume. And also it says consider selected grade group 2 if there is low volume. However, it is arbitrary. But the NCCN says it is preferred in both very low risk group and low risk, and also in a few favorable intermediate risk, wherein they specify saying limited pattern for low PSA density and low tumor volume with a life expectancy of more than 10 years. And AUA says strong recommendation for active surveillance in low risk localized prostate cancer. So across all the guidelines, it is the preferred treatment for low risk prostate cancer and select cases of favorable intermediate risk. So this is a very recent study, that is the prostate active surveillance study, recently published by Dr. Daniel Lin. It shows it included almost 2,155 men with favorable risk prostate cancer, showing 49% of the men remained free of progression, with less than 2% developed metastatic disease and less than 1% died of the disease. So what is the protocol for these patients? Careful selection is needed, with low risk preferably and favorable intermediate risk are optional. And baseline multi-parametric MRI is important, with a confirmatory biopsy within 6 to 12 months if limited original sampling done. And we monitor them with PSA every 3 to 6 months and a DRE annually. And however, nowadays MRI guided monitoring is increasingly used with a repeat biopsy if it is MRI based only when MRI or PSA is changing, or if the systematic without MRI, then it is a 147 protocol, that is first at 1 to 2 years, then every 2 to 5 years. So what are the triggers for leaving active surveillance? That is, when do we reclassify these patients? That is, whenever they upgrade to Gleason grade group 2 or higher, or there is increase in tumor volume, that is more than 3 cores positive or more than 50% of the cores are involved, and PSA density is rising or persistent PSA doubling within 3 years, less than 3 years, and there is MRI progression with a pyrites 4 or 5 new expanding lesion, or patient opts to reclassify himself. So the future directions are, there is MP-MRI based decision making which is coming. So there might be fewer biopsies, which will be encouraging for the patient. And there are incorporating genomic classifiers like Decipher and Oncotype, and personalized active surveillance schedules using modeling algorithms. And there are some controversies like variability between the active surveillance programs internationally. And there is including the favorable intermediate risk groups, which is still debated. So to conclude, active surveillance should be the default for Gleason grade group 1 unless there is a strong contraindication. PSA density is the strongest predictor of reclassification. Early confirmatory biopsy is critical. Long-term cancer-specific survival remains excellent with active surveillance. So coming to my the next second part of my talk, that is the focal therapy. So before starting, I would like to share my experience. I recently visited UCLH London as well as MSKCC for my observership, and I had a first-hand experience in the Department of Focal Therapy. So with that, I could share my experience. So what is focal therapy? It is guided ablation of an image-defined biopsy-confirmed cancerous lesion with a safety margin about roughly around 1 centimeter surrounding the targeted lesion. And so the whole gland treatments the commonly used are radical prostatectomy and radiation therapy, which has problems of sexual dysfunction and urinary problems. So to strike a balance between the oncological control and functional preservation, so this focal therapy has emerged and found its path to minimize the morbidity, preserve continence and potency, and avoid over treatment. So this is the most important slide of my presentation. The crux of the focal therapy lies in this concept of index lesion theory, wherein they believe that though prostate cancer is multifocal, the dominant foci or the most largest, highest grade tumor is which drives the tumor metastasis and progression. So if we can target this nodule and treat it effectively, so that will prevent further progression and metastasis. So that is the basis for partial gland or the focal therapy. So the rationale for this is this is adapted from the FLAIR trial from the radiation people, wherein they gave a boost to the tumor and noted that the cancer-free survival was significantly high compared to not giving a boost to the tumor. And also this is adopted across various solid organ tumors such as even the partial nephrectomy and the breast cancers. So this is adopted from them. So who are the ideal candidates? So the success of focal therapy hinges on appropriate patient selection. So low to favorable intermediate risk prostate cancer patients are the ideal group of patients with unilateral disease on biopsy as well as imaging and absence of high risk features. So we work them up with a multiparametric MRI and MRI targeted and systematic biopsies, and a PSMA PET imaging is optional, and genomic classifiers are also optional. So multiparametric MRI, as Dr. Vishnu has covered it very beautifully, and from the focal therapy fellows, what I got to know from in the Western countries is the focal therapy fellows in the first 6 months, they get to do only transperineal fusion biopsies and freehand biopsies just to get a hang of reading the MP-MRI, so that forms their base or foundation to further enhance their skills in focal therapy. So that is the true importance of knowing the MRI before starting a focal therapy. And also Dr. Santosh, who was recently here in India, who is currently doing his fellowship there, has made a statement that future the focal therapists and the uro-oncologists will be called as either MRI literate or MRI illiterate. So that is the importance of knowing to read the MP-MRI to start focal therapy. So coming to the next various energy modalities, they can be subdivided into thermal and non-thermal. So thermal ones are cryoablation and high intensity focused ultrasound, focused laser ablation, while the non-thermal ones are irreversible electroporation, that is a nano knife, and photodynamic therapy. And there are also emerging therapies like water vapor ablation, microwave ablation, and transurethral ultrasound ablation. So this is the timeline of introduction of focal therapies for prostate cancer. Way back, 2 decades back, this has started in 1999 with the cryotherapy, followed by HIFU and photodynamic therapy, radiofrequency ablation, laser ablation, and irreversible electroporation. So the highest amount of evidence is available in the literature for both cryotherapy and HIFU. So what is HIFU? This delivers focused ultrasound waves that rapidly heat and destroy the tumor tissue via coagulative necrosis. So this can be either done transrectally or transperineally. Most commonly, they prefer transrectal route. This is widely used in Europe, FDA approved in the US for tissue ablation only, not explicitly for prostate cancer. And this also may require multiple treatment sessions. So this is a person, Clement Orzik, who has published this series of 703 patients of.
You have to wind up. You have to wind up.
Yes, sir. So there is significant PSA reduction. So the next to summarize the lesions, To summarize the techniques, the anterior lesions are very much amenable for cryotherapy, while the posterior lesions are amenable for HIFU. So this is the post-ablation surveillance. And coming to the functional outcomes, there is good functional outcomes of urinary incontinence and erectile function. However, there is some amount of recurrence that is in field and out of field. So these trials will give us future directions. However, this is all in the trial setup and not approved for clinical usage. So to summarize my focal therapy findings, it reduces the morbidity, preserves urinary and sexual function, and it can be repeated. Possibility of delaying and avoiding radical treatment is there. However, focal therapy is not a curative intervention for all, but in the right patient with the right team, it can be transformative. Thank you.
So even at the end of 5 talks, we have 159 people on A to Itihas procurement that people study. Ravi Mohan, the focal treatment that you are focal treatment, we have the focal treatment PGI. But how often you are doing it? And what is your selection criteria?
So, sir, I think Amresh should be congratulated that he had a topic which needs one seminar in itself, and he tried to do it in 8 minutes. The major thing which emphasis which he did and which we should also remember is about active surveillance, that low risk patients, they can be offered active surveillance, they should be offered rather active surveillance, because it's not going to kill, they are not going to die because of prostate cancer. So but then because of cross competition, because of lot of fear, patients are so much anxious with the word that they will never accept active surveillance. Even in PGI, we have 1 out of 10 would be maybe accepting active surveillance, but rest 9 would actually fall for one of the surgeries. So in that bracket where you know that these patients are not going to die, these are the bracket of patient where focal therapy plays very well. It doesn't give much complications. It maintains their sexual function, maintains their urinary function, and has some cure which he could not cover eventually, but it almost offers equivalent cure. So that is the bracket of patient where focal therapy is probably the best can be offered. A very small lesion, low risk disease. Now, for rest all patients, surgery remains the standard of care. Now, in India, I think we have only 4 or 5 centers who are actually practicing focal, because per se, we are evolving with radical prostatectomy right now. We are not yet reached to of saturation of radical prostate that we're going to go to focal therapy. So that's the reason why we are not there. Otherwise, focal therapy is specifically limited to a bracket of patients who are suitable for active surveillance but are very anxious.
Okay. Deepak, you want to say a comment? Very big surgeons in US recently, I have seen papers of going to focal therapy. They are talking more about focal therapy. They are extraordinary. I don't mention names, but they were very good radical prostatectomy surgeons, and they are believing that it helps. This is what I have seen.
It's a new toy.
New toy. Yeah.
It's a new
I
toy.
also felt like that. They are bored of what they have done. I mean, it may be appropriate. I'm sorry. Deepak?
So just a question to Ravi Mohan sir. I have visited one center, Hashim Ahmed Imperial College in UK, for the focal therapy. So there they used to do HIFU and cryoablation. Sir, is there any preference like HIFU, cryo, and only is HIFU is more commonly preferred, FDA approved? And what about the saying about the Tulsa Pro, which is a new technique which is
Yeah, I think we have kept on hearing this, Prashant, every meeting about Tulsa Probe. That definitely is good. The only advantage it offers is that it would dynamically readjust your therapy. So that's the only advantage, because it dynamically MRI is trying to readjust the lesion and try to ensure that the lesion is targeted. Now, regarding HIFU or cryo, I think it's mostly largely about availability of the expertise. It won't make any difference whether you use HIFU or cryo, but yes, HIFU is more strongly practiced or more well studied than cryo, because cryo probe is little thicker. So to enter into the prostate is a little challenge, that you're going transperineal or transrectal. It's a challenge. Otherwise, technically speaking, all these focal therapies would be on the same planes with respect to their outcomes.
Okay, thank you. We'll go to the next speaker. Deepak, you introduce from now onwards.
Okay, sir. Our next speaker is Dr. Mujibur Rahman, sir, from Mangalore, Karnataka. He is professor and head of the urology and renal transplant robotic surgery at Yenagoa Medical College. He's done MBBS from Calicut Medical College, general surgery from Trivandrum Medical College, and he has done a fellowship in endourology in Germany, and he has done a robotic fellowship at World Laparoscopic Hospital in 2015. He is a certified console surgeon with the Da Vinci system and Asan Medical Center, Korea. He is authorized in multiple high-impact publications in urology, kidney stones, uro-oncology, and is member of USI, ASU, KUA, EBU, and AUA, and Robotic Council of India. Yeah, welcome, sir. Mujib, sir.
Yeah.
Yeah, thanks for being.
Yeah, hi. Hi.
So,
Hello.
Yeah.
Yeah, hello.
Yes.
Yeah, audible, no? Yeah, hi, Ravi, Chandra, and Kaddu. This one, I'll present radical prostatectomy selection, counseling, and outcomes. There's a little mix-up of topics what we have presented before. That in executive summary, the navigating the complex decisions, the three things have to be taken into consideration: the oncological selection, that is the tumor assessment and curability of the lesion; the physiological reserve, that is the patient's health, comorbidities, and the life expectancy; and the functional selection, that ultimately it go into the quality of life. Then radical prostatectomy, historically, it was a tumor resectability and fitness for anesthesia, earlier days, historically. That with the advent of the PSA screening and advanced technology like robo and multiparametric MRI and all the focal therapies, what was mentioned, probably the focal therapies are coming up, probably with competing with the radiotherapy. Then there is, this has introduced complexities in diagnosis and treatment. And parallel to that, there is a paradigm change in the guidelines as well, because most of the data that has come may mature after 10 or 15 years, once the robo has become very common and it is widely available. And PSA era, again, the selection of the patients, it has made overdiagnosis and over-treatment, like Will Rogers' phenomena, diagnosing lower volume and lower grade over-treatment and over-diagnosis. Then with the technological, again, the selection of the patients in the robotic era, the expansion of surgical feasibility created new criteria in selection of the patients for surgery, the prompting change in the guidelines. Then coming to the first one, the oncological selection, that we get the patients localized, guided by which the diagnosis has come with the PSA, clinical T stage, as well as the Gleason score. We might get not too intolerant, disease aggressive enough to warrant intervention, like the active surveillance, what we said, and the focal therapies, and just right, that is localized enough for a potential cure, that most of the cases what we do for the RARP, and not too advanced, that is not locally advanced or beyond the scope of a primary surgical. These are all the main scenarios we see. Low risk patients normally is the active surveillance, what the previous speaker has mentioned. And exceptions for low risk diseases, the RP, suppose there is a high volume, low risk, multiple positive biopsy cores, or a significant involvement of the per core suggests higher risk of upgrading. And with the advent of germline mutations, BRCA2, we know that all the genetic profiling and grading the tumor based on the susceptibility, genetic susceptibility for high risk recurrence. Then high PSA density and psychological selection. Now, some of the patients, what will happen is surveillance fatigue. They're tired of the severe anxiety. They might, these are all to go for a psychological closure. Sometimes we'll have to select these patients for surgery. And intermediate risk disease, 10 to 20, Gleason score 7. These are all again, the NCCN nuances, favorable and unfavorable it has made, making it more difficult for, as a clinician, to select the patient, which patient should undergo a radical prostatectomy. Then high risk localized disease is a multimodal paradigm. Then we all know the definitions, more than 20, Gleason 4 to 5 and T3A. The modern approach, definitely the RP is a strong option in multimodal strategy, debulking or accurate staging. And selection criteria, sometimes the T4 disease and oligometastatic, these kind of little more advanced high risk also we select nowadays. Then the host factors, what we have to see, the life expectancy, the 10-year rule, the potential survival benefit, we have to prove before selecting the patients. The biological age has to be, the physiological health has to be considered, and the comorbidity, Charlson's comorbidity index, again 10-year rule. Then comorbidities has to be taken seriously before selecting the patients for an RIRP. And especially the comorbidities like CHF, especially when in RIRP, we have to keep the position of the patient down, morbid obese patients, technical difficulty, as well as the complication risk. The functional selection of the patients, before that, we have to see the urinary continence, erectile function, and BPH factor. Sometimes we have the obstructive one with the malignancy. The urinary continence factors has to be taken. This is the most important thing, what the patient, even the positive surgical margin, we have other RT or androgen deprivation therapy, but the continence patients are considered above. The membranous length of the prostate, and what off late, what I have seen is the bladder neck reconstruction is more important than the membranous urethral length. If you have a good bladder neck reconstruction and then anastomosis, it has got a good continence. Preoperative status, that means the baseline urinary function, the condition of the bladder, strength of the pelvic muscles before surgery. These all impact the speed of recovery. Then surgical techniques, the nerve sparing, preservation of the external urethral sphincter, the apical dissection. These are all the things we have to take into consideration. The final thing is erectile function, post-op outcomes, and optimization. This ED affects the quality of life. It needs very good counseling and management. As far as our patients are concerned, this is and the age of the patients, what we address most of the time. ED is stands behind the incontinence and oncological clearance. The ED is a frequent consequent recovery. Normally, they say it's 1.5 to 2 years. And preoperative erectile function, age, nerve sparing, and surgical expertise also takes these factors as into. These are all the predictive factors. And rehabilitation and management, I don't think that PDE5 and vacuum erection devices will not work in this kind of cases. But what we have to do is this intracavernosal injection with trimix or bimix. It has to be started twice in a week, 2 times in a week. You have to start immediately after removal of the catheter, normally with the 9 to 10 days after the catheter. So this corpus cavernosa, it'll go into sleep if you don't activate it in the early itself. And this is one nomogram that shows that bilateral nerve sparing. You see the improvement of the 3 months, 6 months, 12 months, 18 months, and 24 months. And patients who have undergone bilateral nerve sparing definitely see the 75% is the improvement. And trial insights, these are all innumerable number of trials are there in this field. And psychological, this fact has to be taken. The trifecta framework, cancer control, that should be the paramount goal. Urinary continence, key functional concern, and sexual potency must be discussed with realistic expectation. Patients must understand, accept the hierarchy to avoid postoperative regret. And counseling techniques and shaping realistic expectations, managing anatomical expectations, review the MRI with the patient, show them that these are all the lesions. Suppose you have an apical lesion near the, you have to have a continent, you have to have a good oncological and negative margin. This has to be reviewed with the patient. And shared decision making, a strong stream narrative, reframing conversation from loss of function to gain of voiding efficiency in patients with LUTS or BPH, and prehabilitation as a filter, willingness to engage in prehab Kegel exercises, indicate compliance, influence, and include the physiotherapist as well in this. And optimize shared decision making, long-term recovery trajectory, comprehensive educational resources, and inclusion of supportive system. And some of the considerations, what we are in complex scenarios, we are getting a good number of salvage radical prostomy, last resort for local recurrence after RT. You have to sit and discuss with the patient. And definitely the local control. We have so many patients who are presenting with obstruction, bilateral hydronephrosis, this renal failure, and hematuria. This kind of patients, local treatment definitely makes this has to be discussed with the patient. Oligometastatic disease, high BMI, and this all requires a good. In conclusion, the modern radical prostatectomy candidate, the oncological necessity, the psychological readiness, physiological capacity, and functional feasibility. All these parameters has to be taken into consideration before selecting the patients, and the outcome has to be in-depth discussed in a shared decision-making protocol. Thank you. Thank you very much.
Excellent talk, sir. Excellent talk.
Nice.
Ravi Mohan, you wanted to say anything?
No, I think Dr. Mujib, a very picturesque presentation. Try to make categorize things in a simpler way. But I think the primary emphasis is that about surgical counseling. What we lack more than to spend with patient to prior before surgery to into the as well surgical as well as the Kegel part which he mentioned. So that is probably the gist if you want to have a successful surgical outcome, because we all know how to do surgery. What we need to learn is how to communicate with the patient so that if the patient is in sync with you, then automatically outcomes become better.
Thank you. We'll go to the next speaker. Next speaker is Ravi Deepak. Please.
Yes, sir. So the next speaker is Dr. Tanmay. Welcome, Dr. Tanmay. He is currently fellow in uro-oncology and robotic surgery at Amrita Institute, Kochi, and he has completed his MSc Urology from Madras Medical College, and he was a Chinnaswamy Gold Medal winner. Then he was first runner-up for A. Rajashekharan Gold Medal 2023 Madras Urology Society. He has presented multiple papers, posters, video at state, zonal, and national conferences. He has been faculty in workshop and conferences at zonal and national levels. He is author of 2 book chapters and multiple peer-reviewed publications, and reviewer for reputed urology journals, and clinical interest, uro-oncology and robotic surgery and clinical research. Welcome, Dr. Tanmay. He had been a very good junior when he was with us in Manipal Hospital, Whitefield, and there later on he joined uro-oncology fellowship.
But in A to Z research work also is very active. He has very good knowledge about the research and the statistics part. I must appreciate him. Over to you.
Tanmay, you can start your presentation.
Is my screen visible, sir?
Yes.
Yes.
And the voice is okay, right?
Yes.
Yeah.
So first of all, I'd like to really thank Dr. Deepak and Dr. Chandramohan for the opportunity and such a wonderful introduction beyond my expectations. So my topic is radiation therapy options in prostate cancer, a urologist perspective. So I was told to keep this presentation basic, and definitely that is needed. 1.5 hours into this webinar, and especially discussing after radical prostatectomy will be a task. So I'd like to begin with the scheme of my presentation. I will stick mainly to the modalities and patient selection rather than stressing on each aspect of radiation therapy and its planning. So firstly, mechanism. How does radiation affect the cancer cells? First point is it carries out a significant amount of DNA damage, causes breaks in double-stranded DNA, causes a lot of free radical formation, which in itself is cytotoxic to cells. There is a cell cycle sensitivity in patients of prostate cancer because they are mainly in the G2M phase of the cycle. And also there is a lot of changes in the tumor microenvironment, which leads to, again, cytotoxicity in these cases. So coming to the modalities, broadly, we have divided it into 2 types. There's external beam radiation therapy and there is brachytherapy. I will talk about each of the subdivisions of those in depth. So external beam radiation therapy, as the word suggests, the radiation source is outside the body. So we are using X-rays generated by a linear accelerator. Conventionally, there was significant acute and late toxicity associated with this treatment. But now we have moved on to something called as intensity modulated radiation therapy. Now, in this technique, what we are doing is there is different parts of the beam of radiation have a different intensity. So that gives a shape that conforms to the shape of prostate, thus allowing us to give a very precise targeted radiation in these. In guidelines, we many a times encounter the word VMAT, which is volumetric modulated arc therapy, which is just one of the ways of delivering IMRT. The machine that gives it is in an arc format. IGRT, just to simplify it, is nothing but IMRT where there has been a real-time or daily imaging, preferably CT scan, and that corrects for daily organ motions and allows narrower margins of error. The newer kid on the block is stereotactic body radiotherapy, SBRT, or SABR, as certain Western countries call it. It provides a very high dose of radiation given in 5 precisely targeted fractions and has some advanced motion management. So we are giving faster treatment to smaller targets. A variation in that, an advancement, I would say, in that is CyberKnife, which is essentially a robotic mounted accelerator with tracking of the target organ's motion, which is done in real time. Because we are giving large doses, these sessions last up to 45 minutes, and therefore, within those 45 minutes, the organ movements are tracked, and that gives more precision. Another variation of EBRT is the proton therapy, which is a relatively costlier option. It possesses something called as Bragg peak phenomenon, in which majority of the radiation dose is deposited within the tumor with almost no exit dose and provides maximal normal tissue sparing. Now, brachytherapy is when the radioactive sources are placed inside the organ. That can be of two types: low dose rate brachytherapy and high dose rate brachytherapy. Low dose rate is permanent implantation of brachytherapy seeds within the prostate, and high dose rate is a temporary implantation using something like a catheter. So, with high dose rate, we have a quicker delivery of radiation dose, and subsequently, because it is delivered over a shorter period of time, even the acute side effects will resolve much earlier compared to LTR. Now, fractionation is an important concept when it comes to radiation, especially EBRT. Conventionally, each fraction was 1.2 to 2 grays of radiation given over 37 to 45 fractions. Fraction is nothing but a session. It was given in 37 to 45 session, which is essentially over 37 to 45 days. So because of that prolonged schedule, there was concern for toxicity. So now we have moved to moderate hypofractionation, and with the advent of SVRT, we have something that is ultra hypofractionation, which means very high doses in just 5 fractions. It is supported for in low risk and intermediate risk patients. And there are these two trials when it comes to SBRT. We have the PACE-B trial, which has shown similar biochemical control and comparable toxicity with a mild increase in GU toxicity. And we have an ongoing NRG GU005, which is comparing SBRT to moderate hypofractionation in intermediate risk patients. So why are we trying this hypofractionation? Firstly, conceptually, the prostate tissue has very high alpha to beta ratio, very low alpha to beta ratio, sorry, which permits its sensitivity to higher dose per fraction rather than frequent smaller doses. Other important factors of consideration are slower tumor proliferation and strong synergy with ADT, which gives an edge for hypofractionation. Now, I won't deal much with planning and preparation because that's what our radiation oncologists do. The first step is simulation. They will run a CT simulation scan and superimpose sometimes an MRI or a CT PET MRI image on it to properly plan the region of interest. And contouring is essentially marking out the region of interest. Motion management may be done with real-time tracking or fiducial insertion, and then the technique is chosen. And just before, a quality assurance is done to do a pre-treatment verification. Coming to the main crux of the presentation, that is treatment selection, patient selection. So this is a table I have kind of summarized from the EAO guidelines. I might have missed a few points, but I tried to make it as simple as possible in one slide. So here it is. With low risk localized cancer, as we know, active surveillance has become more and more the treatment of choice. But in those cases, some SBRT might be given, that I'll add on later. The categories I have divided are localized intermediate risk, high risk and very high risk, and post prostatectomy. So for intermediate and high risk, very high risk, the dose is 76 to 80 grays, which is given by IMRT plus IGRT format when EBRT is given. The only difference being that in high risk and very high risk patients, we'll also add a whole pelvis radiation. The duration of ADT will vary. In intermediate risk, it will be 4 to 6 months, whereas in the high risk, 2 to 3 months. And an LDR monotherapy can be offered in a localized intermediate favorable risk, whereas in an unfavorable or a high risk, it will be a brachytherapy boost. Now, I won't deal with the dosages, but when it comes to a very high risk tumor with multiple high risk factors with a clinical node positive, we can add 2 years of abiraterone as per the guidelines. When it comes to the post prostatectomy setting, we have adjuvant and salvage therapy. The dose is around 64 grays and 4 to 6 months of ADT is recommended. Now, adjuvant is slowly phasing out. We have moved to doing an early salvage treatment when 2 consecutive PSA rises above zero point 0.2 are seen. Even with a negative PET, it is recommended that we start the salvage therapy in these cases. SBRT and hypofractionation are only recommended in low and intermediate risk. It is being studied in high risk patients. RT in metastatic and palliative disease, we have prostate EBRT given an oligometastatic disease as per Stampede trial. For palliation, we have painful bony mets and hemostatic RT again recommended to the metastasis, that is metastasis directed therapy. I have already covered who all needs ADT. Follow-up is by routine history, PSA, and imaging is only when it is required. After RT failure, local salvage, multiple therapies have been tried, but they are only recommended in the trial setting and in experience center. An important point is the Phoenix criteria. A PSA value of more than 2 nanogram per ml above the nadir PSA is considered as a biochemical recurrence. Last 2 slides on toxicity and the mitigation, because this is important when we want to convince the patient to undergo surgery. So acute toxicity is when within weeks of starting RT, there is fatigue, urinary frequency, GI disturbances, but usually these are common but temporary, self-limiting. Late toxicity is of concern, especially when it's a high-grade GI or GU toxicity, but luckily the rates are low of around 1 to 3%. Erectile dysfunction, even though lesser when compared to surgery, is still seen in radiation, especially when there's a low baseline function, advanced age due to giving of ADT, and also an extreme rare risk of giving a secondary malignancy. How to reduce these toxicity? We use the modern techniques of IMRT. We use something called as rectal spacer, where a hydrogel is injected transperineally between the prostate and rectum to separate the rectum away from the prostate, and that can be automatically absorbed by the body in 6 months. I'll skip the grading of severity of adverse events, and I'll keep this as a final slide, a small comparison I drew out between surgery and radiation from the guidelines. That's all. Thank you so much.
Excellent.
Excellent
Presentation. In fact, all the speakers, Ravi Mohan, you are understanding, majority of the speakers are evolving uro-oncologists. I have not taken stalwarts this time. Second to stalwarts who are working with them, I have taken. It's really, really commendable. 6 talks. I was not able to stop you people. I want to listen, and 150 people are still listening. That should be the way. This webinar will be recorded, and we will put in all ASU groups. This gives laurels to ASU also. What do you say, Ravi Mohan?
Absolutely, sir. Absolutely. I'm amazed and very happy that the future of uro-oncology is with such a strong force. All of them I know personally because they have been part of all the uro-oncology meetings which we had in the past. But yes, that's very impressive. Regarding his talk,
Thank you. Deepak, thank you for selecting all the people. You are the instrumental. I'm only talking, but he is the one person man this. Mohan.
Regarding talk, Tanmay, very nice talk, but from a urologist perspective, since one thing is that uro-oncology is not a single person's game. So that's why this topic is essential, that we as a part of team must know each other, what we are doing and what they are doing. That's essential. In our practice, we typically always do a Euroflow before a patient goes for radiotherapy, which is so that because you don't want, and you also need to counsel the patients. One thing which we counsel normally is in a patient who is fit for both fit for both we would typically tell them that surgical complications are finite and they're maximum to begin with, and they improve with time. Whereas radiotherapy complications, they are multifactorial. You can have rectal, celiac, everything, and they increase with time. They don't improve with time. They may be very minimal to begin with, but it increases with time. So these two things, as a urologist, we must emphasize as well, so that patients are educated. Yeah.
Absolutely agree, sir. I'd like to just add one point. In that case, the salvage, if a radiation therapy fails, doing surgery becomes extremely difficult, whereas after surgery, you always have the option of doing a salvage radiation.
Yeah, so Tanmay, one question, when you are referring to the radiation oncologist, and you have any preference while referring this kind of therapy should be preferred for this patient, like as you mentioned in the slide, post prostatectomy or high risk prostate cancer, you will refer?
So the standard remains EBRT in most intermediate and high risk patients. But if it's a very old and frail patient, we have a CyberKnife in our center, so we directly refer for CyberKnife in those cases. With ADT and CyberKnife, they'll have a fairly good quality of life, reduced morbidity, and a decent disease control also. It is not approved in a high risk setting, but there are a few trials coming up which are showing a good result with that.
Thank you. We'll go to the next speaker, Deepak.
Yeah. So our next speaker is Dr. Hemnath. So he is consultant urologist and robotic surgeon at Preeti Urology and Kidney Center in Hyderabad. He has done his MBBS from Kanyakumari Government Medical College, MS from Stanley Medical College, MCH, he's a gold medalist from Madras Medical College, and he has been fellow in endourology and laparoscopy, a recipient of Raj Shekharan Gold Medal Award at Dr. MGR Medical University. He is a recipient of Raj Shekharan Gold Medal Award for Madras by Madras Urological Society as well as in 2019. Second prize at USI Best Studio 2022, and has multiple publications in national and international journals. His field of interest is endourology, laparoscopy, uro-oncology, and robotics. Yeah, so welcome, Dr. Hemnath.
Thank you for the introduction, sir. I'll share my screen.
Yeah.
So good evening, seniors and friends, and thank you ASU Council, Dr. Chandramohan sir and Deepak sir for giving me this opportunity. So I'm going to talk about the management of metastatic hormone-sensitive prostate cancer. So these three terminologies are interchangeably used. The hormone naive, what we used to call previously, and now we are moving on to the hormone-sensitive prostate cancer to focus on the AR dependence of these cancers. And now slowly the emerging thing is the castration sensitive, highlighting the limited therapeutic window that we have. So when we talk about the metastatic hormone-sensitive prostate cancer, this is just a transient phase of the natural course of the prostate cancer patients, and it ultimately spirals down into the castration resistance phase. So we have a limited opportunity to act. That's why I have kept it as hitting hard and hitting early in these cancers. So the limited window of opportunity that we have, as I told, is only 11 to 18 months if we are giving only monotherapy of this ADT, and the recent treatments like triplet and doublet therapy, we are trying to bring it up to 3 to 4 years, but still this eventually progresses to castration resistance. So the important thing about these patients is first we have to classify these patients and prognosticate these patients by proper evaluation. And most of us nowadays go for PSMA PET scan rather than the conventional imaging. But we should remember that all these the protocols, all these data that we have are done with only the conventional imaging like bone scan and the CT scan. So the basic thing that we use for categorizing these patients as low volume disease and high volume disease is got from the chartered trial. So which states that either 4 or more bony metastases, one at least one outside the pelvis and the vertebral column, and visceral metastasis, whereas the latitude defined it as either 2 of these things, like 3 or more bony mets, visceral mets, and Gleason score 8. But practically we are using the chartered definition. So, and we must remember that this is according to the conventional imaging and not the PSMA PET scan. So next comes the prognostication of these patients based on the synchronous metastasis or it is a metachronous metastasis. This has a very impactful implication on the outcomes of the patient, where the synchronous de novo high volume disease has poor prognosis, whereas the metachronous low volume disease has a favorable prognosis. And one more important prognosticating factor is the PSA at 6 months. The PSA, if it falls below 0.2 after start of ADT, that is a good prognostic factor. Whereas if it is more than 0.2, it's a poor prognostic factor. How to this treatment of these patients has undergone a sea of changes from the surgical castration that we used to do a decade back now to the more personalized treatment based on the genomic profile of the patient. This has undergone a lot of changes, and these are the various trials and the drugs that are come up in a big way in treatment of these category of patients. And the base for all these treatment, whatever we add upon the newer drugs, the base for all these is the ADT. ADT in the form of either surgical castration, LHRH agonist or antagonist. All these three effectively brings the castration level of testosterone. Surgical castration being the fastest, achieves in 24 hours, whereas the antagonist achieves it in 3 to 4 days, and the LHR agonist takes about 2 to 4 weeks. But we should remember that surgical castration is irreversible. Agonist has the flare phenomena that has to be taken care, whereas antagonist is apparently called a better cardiovascular risk profile for these kind of patients. So the choice depends on the patient and also the surgeon. And we all agree upon one thing is that the ADT monotherapy is no longer the standard of care, and it is used only in very select patients whose performance status is very poor and not eligible for any other treatment. Now, the word coming up is the ADT intensification. So the ADT monotherapy treatment is abolished, and we always add upon something else to the ADT and intensify the treatment. And this has been the paradigm shift in this category of patients. So why this intensification? The numerous trials have shown that significant survival advantage with adding upon either APRIs or the docetaxel for these patients. And the biological rationale for this is that hit the tumor very hard early, so that it targets the diverse clones and prevents the resistance that develops later on. And the progression to CRPC can be delayed significantly, and by thereby improving the quality of life for these patients. And a lot of drugs have come up: abiraterone, enzalutamide, apalutamide, darolutamide. These all have now become the first choice treatment for the metastatic hormone-sensitive prostate cancer.
3
So,
minutes.
when you consider a high volume disease, the doublet therapy, all the trials, phase 3 randomized trials, all have shown a significant improvement in overall survival, as you can see in the last column. And whereas not so significant for the radiotherapy if you add upon a radiotherapy for high volume disease. Whereas the change that you're seeing from the previous table to this one is that the docetaxel has become less effective in low volume disease, and the radiotherapy additional benefits are there for the low volume risk patients. So we all know that this chartered trial shows the overall survival benefit with the docetaxel is for the high volume disease patients and not so for the low volume disease patients. The Stampede arm C also showed a similar overall survival advantage for adding upon docetaxel along with ADT. And for the abiraterone, the Latitude trial has shown beyond doubt there is significant improvement in overall survival and also radiographic progression-free survival for these patients. And the Stampede trial arm D has reinstated the same factor as it improves the overall survival and failure-free survival for these patients. And a lot of other androgen receptor pathway inhibitors, second generation drugs like enzalutamide as proved by the Enzamet's trial, and the apalutamide as proved by the Titan trial, has shown overall survival benefit and progression-free survival benefit also. And as far as the Arches trial and the Chart trial for the resvilutamide, there are interim results that is showing promising results. And also the Aeronaut trial for the darolutamide showing very promising results, even though these are preliminary interim reports, not the final reports. And even though we are satisfied with the doublet therapy, we are still pushing and trying to use our the maximum power in treating these patients with triplet therapy also initially itself. This is called the triplet therapy by adding upon ARPIs along with the docetaxel and ADT. This is proven beyond doubt that there is overall survival advantage with adding upon the third drug in addition to the ADT and docetaxel. The Arasens trial shown that darolutamide addition to the docetaxel and ADT has shown overall survival benefit, especially for higher volume disease. So this triplet therapy has to be considered for higher volume disease, and also secondary endpoints also there are significant improvement is there. And also this PEACE-1 trial for the abiraterone, adding up of abiraterone to dosi and ADT has also shown improvement in overall survival, especially in high volume patients. And also time to, if you add upon, there is one arm in this trial that has added radiotherapy to the local site, and that has shown time to serious genitourinary events is also reduced significantly. So with lot of options in our hands, how to choose whether doublet therapy or triplet therapy, that depends on patient factors, the drug factors, the comorbidities, lot of things. So basically, if the patient is having a low volume metachronous disease and slightly lower performance status, and there are a lot of comorbidities, we used to go tend towards the doublet therapy. Whereas if the patient is very fit, healthy, high volume disease, synchronous, we used to hit them with the triplet therapy upfront. And cost is also an important consideration when selecting these drugs, because these are costly affair for any patient. So we are pushing our boundary a little bit more. Do we treat the primary also? Yes, why not? So that is shown by Horrocks trial and the Stampede H arm that has shown radiation, adding upon radiation to the primary in low volume setup, that is oligometastatic disease, has provided some benefit, not in the terms of overall survival, but at least progression-free survival, there is benefit. And also PEACE-1 also showed addition of radiation is helpful. And we as surgeons, we try to go beyond that. And why not radical prostatectomy? Still now the trials are ongoing, and we have not reached a final conclusion, so it's still pending. But radical prostatectomy also is an option in experimental setting only. And why not treat the metastasis also? Why not give a curative option for all these patients? Those lot of studies there to analyze this, and they have shown a progression-free survival, and also the time for castration resistance is prolonged. So all the guidelines have unanimously accepted all these things, what we have spoken till now. And radiation monotherapy is to be not recommended, and triplet therapy for high volume fit patients. The consequences are, if we use all our armamentarium upfront, what else we are left with? So hopefully the next speaker will have answers for that. And we are not given much choice for him to treat these patients when the patient ultimately progresses to castration resistance. And also sometimes we over-treat these patients. So triplet therapy for low volume is not recommended. So, and also there is a toxicity that can happen. And also these cancers, when they are hit with multiple targets, and they can go into a resistant form, and they may not respond to any other treatment in the future. And financial burden is also there. These are the flaws of this. And when to do genetic testing? Now, unanimously, all the guidelines are stated for all the patient, irrespective of the castration resistance or sensitive, they has to undergo somatic and germline mutation testing for the BRCA mutation and all the somatic profile also, to basically to categorize the patient who are all eligible for PARP inhibitors or immunotherapy. And also sometimes aggressive variants can undergo triplet therapy upfront. So this is not something in future, it is now in the present, not in the future. So future will be a tailored approach where a favorable risk patients will have ADT, ARPI with local treatment and metastasis directed treatment, whereas adverse high volume patients will go for a docetaxel treatment, triplet therapy or platinum based or a PARP inhibitor or platinum based chemotherapy. So these are the trials that are coming up and hopefully they will add upon the confusion that is already existing. And I want to conclude my talk with this slide. So categorize the patient high volume or low volume, synchronous or metachronous. High volume patients, if they are fit, consider for triplet. Low volume patients, if they are fit, consider primary treatment with radiation also, along with the doublet treatment. So thank you for your patient listening.
Thank you. I think we have overshooted time. Nice talk. The last slide was quite conclusive. I think Ravi Mohan, sir.
We'll go to the next speaker. Good presentation. Ravi Mohan, anything to comment?
No, sir. Thank you.
Good.
Yeah,
Nice
our next speaker
presentation,
is
Hemant.
Dr. Ravi Chandran. So Dr. Ravi Chandran is recently moved to Sparsh Hospital. He's consultant neurologist and uro-oncology and robotic surgeon at Sparsh Hospital, Bangalore. He is former consultant uro-oncologist at Apollo Hospital, Bangalore. He has done his fellowship in uro-oncology and robotic surgery from Amrita, Kochi. He is winner of CKP Menon Best Paper in UCCon 2020, IGU Best Article Award, second prize UCCon 2022. He has multiple, more than 25 national presentation, faculty and panelists in UCCon and regional conferences and uro-oncology conferences. Published many IGU, extensively in IGU, JASU and Journal of Urology. And he has been panelist and moderator role in across national and international conferences. Clinical focus is prostate, bladder, kidney cancer, and robotic pelvic oncology and precision surgery. Welcome, Dr. Ravi Chandran.
My small request is we will not push the last speakers. My sentiment is that they should be given respect. More than 100 people are there, still audience. We don't make you hurry, but we'll give 1 minute more. In fact, calmly you present, no problem.
Thank you. Thank you, sir, for the opportunity. So I'll be speaking on stepwise management of metastatic CRPC 2025 approach. Is my presentation visible? Am I audible?
Yeah.
Yes.
Great. So my presentation will be in a way that we have a resident sitting, and if a patient of metastatic CRPC comes to him for a consultation, how is he going to manage the case? So before we do that, I want to show you the metastatic CRPC management back in 2014, how it was managed. This is to understand the way the landscape, the treatment landscape has changed. So back in 2014, if the imaging is showing a distant metastasis, first thing we would do is to maintain castrate level. That is either do the orchidectomy or continue on ADT. That is a must. And then bone-related management was added. And if patient is symptomatic, you would give docetaxel or radium-223 if it's a bone-only metastasis. Abiraterone and enzalutamide was there in 2014, and palliative RT, so on and so forth. If he's asymptomatic, then Sipuleucel T was given, which is irrelevant for us in India. It has never came here. And apart from that, there were things like anti-androgen, enzalutamide, ketoconazole, and corticosteroids. If you look at this 2014, majority of this approach has been, is faded out. We don't practice it anymore. And this is the latest NCCN guideline for management of metastatic CRPC. Here you can see they have classified into 3 ways. One, whether any ARPI is already given or not. If so, how do we go about it? If already it is given before docetaxel, how do we go about it? And if there is a triple therapy already given, how do we go about it? If you look at it, the current treatment management is mainly dominated by abiraterone, enzalutamide, and docetaxel. And as a second line and third line, it mainly depends on the molecular biomarkers, and they are directing the further treatment approach. So this is the main difference what we have seen over the last 1 decade, that the molecular diagnosis is the way forward, and that is going to direct how we are going to approach these CRPC patients. So coming to workup and treatment of metastatic CRPC, any metastatic CRPC, after confirmation on imaging, those patients, if possible, have to get the metastatic lesion biopsied, and somatic testing has to be done for homologous recombinant repair or for microsatellite instability deficiencies. And subsequently, the treatment decision will be made. As I already mentioned you, ADT has to be continued to maintain castrate levels of serum testosterone irrespective of the resistant state, and bone health has to be taken care of. If it's a small cell or neuroendocrine, the treatment is cisplatin etoposide combination, carboplatin etoposide combination, so on, so forth. However, adenocarcinoma is the most common variant. So let's focus primarily on adenocarcinomas. So first step is molecular diagnosis. So what do we do? A patient of metastatic CRPC is sitting across you. You have done imaging, either be it a bone scan, CT, MRI, or a PSMA PET CT. If possible, a metastatic lesion has to be biopsied, not the primary prostate. If it's already done, well and good. If not, the metastatic lesion has to be biopsied. A somatic tumor testing is recommended for all the patients who have progressed to metastatic CRPC. For benefit of residents, what is the difference between somatic tumor testing and germline testing? Somatic mutation is what happens exclusively in the tumor. It is not present in any other cells. It happens only in the tumor. Whereas the germline mutations are the one that gets inherited, and those mutations are present in all the cells. So for somatic tumor testing, the tissue has to be taken from the lesion, either the primary or the metastasis. For the germline testing, you can take the sample, either be it the blood or saliva, anywhere, and you get the tests done. So apart from this metastatic biopsy, if it is not possible, there is a role of blood evaluation looking for circulating tumor DNA assay, which is coming in a big way. And that's the future of oncology, if you ask me. So all the patients of metastatic CRPC, somatic tumor testing is a must, and so is germline testing. So there are three things that we try looking for. One is homologous repair, which is present in 23% of metastatic CRPC patients. What are we looking for in HRR mutations, BRCA1, BRCA2, ATM, so on and so forth? The main things is BRCA1 and BRCA2 because it has therapeutic feedback for us to give. So how do we do this homologous repair testing? One is next generation sequencing. For HRR, we have to get NGS. The IHC, BRCA1, BRCA2 IHC are not so reliable. On NGS, if BRCA1 and BRCA2 is positive, then you subject them for germline testing. You do a pre-test counseling for the family and ask them to get a germline testing done. If BRCA1, BRCA2 is positive, then there is a strong case for use of PARP inhibitors like olaparib, niraparib, and talazoparib. Apart from homologous repair, we are next looking at MMR defects, mismatch repair defects, which are seen in around 5% of metastatic CRPC. And that includes MSH2, MSH6, MLH1, and PMS2. MMR defects can be looked with IHC and better with NGS, next generation sequencing. IHC is good enough for picking up MMR defects. And if there is an MMR defect, it's a strong case for use of immunotherapy like pembrolizumab. The other testing is tumor mutational burden that is done with next generation sequencing. Once you have a tumor mutational burden report, it is either given as low, intermediate, or high. The report itself will give as low, intermediate, or high. If there are more than 10 mutations per megabyte, then it is considered as high. In those cases, there is a strong role for pembrolizumab. So if there's a patient with metastatic CRPC, if you can biopsy the metastatic site, well and good, that is preferable. If not, primary can be biopsied and you can do a somatic tumor testing. The future is going to be circulating tumor DNA assay by a simple blood analysis. And offering germline testing is also recommended for NCN. If not for anything, somatic is bare minimum required. IHC is good for picking up MMR defects, whereas next generation sequencing is required for picking up HRR defects like BRCA1 and BRCA2. If there is a HRR defect, PARP inhibitor, MMR defect, immunotherapy, and TMB helps in looking at the role of pembrolizumab. So how do we select the patients for the treatment? One, patient and his comorbidities and what is his performance status, whether he can tolerate the treatment that we are going to offer or not. Second is what was the previous treatment that he was offered, whether it was ADT monotherapy or whether it was ADT with ARPI or any chemotherapy was given, so on, so forth. And as we have already seen, knowing the genetic alterations and defects is very, very crucial for managing these CRPC patients. And knowing histological variants. If it's a small cell, then we know the treatment is going to be cisplatin, etoposide, so on and so forth. And if it's an adenocarcinoma, it's a different ball game. Symptomatic versus asymptomatic, visceral versus non-visceral. If it's a visceral, there is a strong case for chemotherapy-based approach, either with docetaxel or cabazitaxel. If it's symptomatic only with the bone, then radium-223 has a role. For asymptomatic, Sipuleucel has a role, but we don't have it in India, so it does not matter. So this is about the gist of patient selection and molecular diagnosis basis for treatment of metastatic CRPC. This is a very simple flowchart which I have made for easy understanding based on all the guidelines. So for a resident, let's say there is a metastatic CRPC patient who has just undergone channel TURP and orchidectomy, and now he is presented with metastatic CRPC. In those patients, there is a benefit of giving either these novel ARIs like abiraterone or enzalutamide or docetaxel. Both are equally good. NCCN says that abiraterone and enzalutamide is preferred over docetaxel. So either of these two options, depending on the logistics and expertise, can be offered. And in patients where orchidectomy has been done and patient has already taken 6 or 8 cycles of docetaxel and now he has developed resistance, in those patients, you offer them either abiraterone or enzalutamide. The third case scenario is where patient has undergone orchidectomy and he has already tried abiraterone or enzalutamide and is now progressing. In these patients, strongly we recommend to get this BRCA, the next generation sequencing test, and see the status of BRCA mutation or HRR mutations. If these patients does not have these mutations, then docetaxel is preferred. And if these patients have BRCA or HRR mutations, then we have these new generation drugs like olaparib and rucaparib. These have to be offered. I don't want you to bother too much about the drugs, combinations, and trial. You can take a snapshot of this screen. In bracket, I have given the trials that have made it as a standard of care for these recommendations. And the ones in italics, they're all category 2B recommendations, whereas rest all are category 1. And if a patient has already received triple therapy, which Dr. Hemnath was mentioning, that if it's too many drugs are given, what is a sequencing conundrum? And in those patients, cabazitaxel has a role to play, docetaxel rechallenge has a role to play. Otherwise, depending on the mutation status, olaparib and rucaparib has a role to play. So to keep it simple, the first line will be abiraterone, enzalutamide, or docetaxel. Depending on the logistics, depending on the patient comorbidities and the performance status, either of the three can be taken. And NCCN guideline says that abiraterone and enzalutamide is a little bit preferred over docetaxel. But to my mind, all the three are very good option for first line. In case patient progresses, let's say he progresses on docetaxel, then switch to abiraterone or enzalutamide. If he's progressing on abiraterone or enzalutamide, switch to docetaxel. And if they progress beyond that, then you look at the second line treatment where you're looking at the mutation status and you have to look at combining PARP inhibitors along with ARPIs, so on and so forth. If the patient has progressed on enzalutamide, then you can probably give a niraparib and abiraterone combination. If he's progressed on abiraterone, probably you can give talazoparib with enzalutamide combination, so that we are introducing a new element to surprise those tumor cells. So this will be the second line management. If already a triple therapy has been given, then cabazitaxel has a role to play, but cabazitaxel has severe side effects and it needs to be managed carefully. Docetaxel rechallenge is also an other option. So if your first line abiraterone, enzalutamide, docetaxel fails, switch them as a part of second line. Even if they fail as a third line, probably you can combine PARP inhibitors along with these ARPIs. When everything progresses, then finally you can look at options of lutetium PSMA therapy. You have Vision and TERAP trial, which have proven it as a category 1 in triple therapy failed patients. For lutetium PSMA therapy, there should be a PSMA positive lesions. If there are if the dominant ones are PSMA negative, then the lutetium therapy may not really be helpful. So you do PSMA PET CT and ensure that your dominant lesions and the majority of lesions are PSMA positive so that you get better response out of lutetium therapy.
Yeah.
And if it's a symptomatic bone metastasis, then radium 223 is a go-to modality. And if there is a high MSI or high tumor mutational burden, then pembrolizumab can be given. In last year guidelines, pembrolizumab kind of had a category 1 recommendation, but the recent one, they have pushed it down to category 2B. And in all these patients, you need to ensure that the bone protection is taken care of either with zoledronic acid or denosumab, which my next speaker would be highlighting on. So continue your ADT, go first line, second line, and third line. Ensure that molecular biomarkers are done so that subsequently you know which direction to steer the ship. And the last part is about metastasis directed therapy, even in metastatic CRPC, where a higher palliative dose of RT is given. It is not curative, it's just a form of a cytotoxic therapy, and it's preferably in oligometastatic CRPC setting, where on CT and MRI you have more than 5 mets, or in PSMA PET, even more than 10 mets is newly classified as oligometastatic CRPC. So in oligometastatic CRPC setting, you can try giving metastasis directed RT. So what we do is systemic therapy is required, ADT, ARPI, docetaxel, combinations of PARP, whatever you feel comfortable, that has to be given. RT can be given to primary, and concurrent metastasis directed radiotherapy can also be given. And they're all still in trial setting to be clear. And SBRT is what is generally recommended. So with this, I wrap up my talk stating that molecular diagnosis is going to steer the direction of metastatic CRPC treatment. And it is important that we understand with vast majority of us showing interest in uro-oncology, it's high time that we don't lose grip on this status. The moment the patient is CRPC, we hand it over to medical oncologist and totally ignore it. But I think going forward, we need to be able to manage these metastatic CRPC patients as well in a team-based setting, and we should be able to steer the ship of management of metastatic CRPC. Thank you. Thank you so much.
Thank you, Ravi Chandran. Anything comment, Ravi Mohan?
No, sir, I think he made it very clear.
Clear.
Absolutely crystal clear.
Absolutely crystal. All these speakers are amazing, except that Ravi Mohan is staying 2 hours. I know as Professor PJ, even though he was my junior, he is very hardworking. 2 hours, one professor keeping it one place. Though he is my junior, I am really thankful. Just spare another 10 minutes, Ravi Mohan. I know your comments, people like you for your knowledge. See, I am feeling that I am most updated today. Instead of doing one more dance, I will listen this talk again. I wanted to keep this talk and listen again so that I can quickly come back to the general urology updated. Thank you. Now, next speaker,
Last speaker,
Dr. Manas Panda.
Panda. Yeah, so he is the consultant urologist in Chennai Urology and Robotic Institute, Curie, Chennai. Completed Vatikoti Fellowship at the Curie Hospital in 2022-23. His special expertise in uro-oncology, robotic surgery, and andrology and reconstructive urology. He has experience in cadaveric and live renal transplant. He has done DNB from Saifi Hospital, Mumbai, and DNB from Lilavati Hospital, Mumbai. He is dedicated and patient-focused clinician with strong communication and teamwork skill. Welcome, Dr. Manasanjan Panda. Yeah, you can start sharing the slides and start the talk. So his talk is on prostate cancer survivorship.
Yeah.
Manas,
Hello,
hello, Manas, you're,
Manas, unmute.
I think you're muted. Yeah.
Manas, unmute.
Yes, sir.
Yeah. Go ahead.
Is it visible, sir?
Yes, yes.
Good evening, everyone. Thank you, sir, for the kind introduction. Thank you, Dr. Chandramohan, sir, and Dr. Deepak, sir, for the opportunity, and Professor Ravi Mohan, sir, for agreeing to be an expert on this session. Before we conclude and say good night, I shall briefly try and brush up on this topic given to me. A patient is labeled as a survivor the day he is diagnosed with prostate cancer. Prostate cancer, as we know, is the most common cancer among men after skin cancers, and the number of survivors is increasing by the day as the prostate cancer survival rates. We can see here is the 5-year survival rate for a patient is touching approximately 95 to 100%. And the 10-year survival rates touching up to 92%, with the 20-year survival rates up to 80% in the younger men diagnosed and treated with prostate cancer. The core goals of follow-up to detect the recurrence, to manage the complications, and to monitor the ADT side effects. The first goal of detecting recurrence is an early detection of recurrence enables timely interventions and definitely improved patient outcomes and enhanced survival rates. Managing the complications at an earlier time, like urinary, sexual, or bowel issues, helps in improving the quality of life. And ADT, monitoring the ADT effects helps in intervening and maybe timing the ADTs to reduce the side effects and giving additional treatments if required. The follow-up schedules depend on the treatment received. For a patient post RARP, the first PSA is repeated at 6 weeks, as Ravi Mohan sir mentioned, because of the half-life being 7 days after 4 to 6 half-lives. That itself will give us the baseline from which the further follow-up of the patient and the further expectations of the patient can be tapered. Post radiotherapy, we do it at 3 months and repeat it up to 2 years to get to a nadir PSA. And from there, the PSA levels are monitored and compared with the nadir levels. Post ADT, in a patient on ADT, the patient has to be reviewed every 3 to 6 months to regulate and manage the treatment side effects. And the treatment follow-up will also depend on the risk stratification at the beginning. In the clinical visits, what are the main aspects that are to be looked at is the PSA levels, the urinary symptoms like frequency, urgency, incontinence, which may be related to the treatment received, some bowel issues, which may or may not be due to the treatment receiving, like radiation or ADT. Bone health, the most important and less talked or less taught factor in the management of prostate cancer is bone health. A patient with prostate cancer is naturally prone to have more loss or the bone mineral or reduced bone mineral density due to treatment or as such due to old age. The various modalities of checking for bone health are DEXA scans. Baseline DEXA scans can be done in certain patients if indicated. The repeat scans can be done 1 to 2 yearly. FRAX tool is a 12 questionnaire with 12 points, which determines the fracture risk of a particular patient. The most effective strategies are the most commonly less talked ones, like exercise. A regular physical activity strengthens the bones and improves motility. The calcium, the nutrients rich in calcium and vitamins, and certain medications. Now, what are the guidelines for the medications? Guidelines recommend 1200 milligram of calcium and at least 800 to 1000 international units of vitamin D3. Other medications like bisphosphonates, zoledronic acid is the most commonly used. It is given IV once a year up to 3 years. Denosumab is given subcutaneously every 6 months, but calcium monitoring is also essential. Radiopharmaceuticals like radium-223 IV is given, but only in very specific and indicated cases. The risk of fracture when used in concurrence with abiraterone is higher. So the indications of starting bisphosphonates, denosumab, or other bone strengthening medications are metastatic or castration-resistant prostate cancer. In non-metastatic disease with osteoporosis or high-risk osteopenia, it may also be given. It is usually not indicated or not commonly prescribed in patients with newly diagnosed metastatic prostate cancer, as it does not provide an upfront benefit. Coming to the other aspects, urinary complications like stress urinary incontinence is more common after radical prostatectomy. There are various ways of improving the continence with time, like regular Kegels exercises, and other therapies like biofeedback therapy may be started if the patient is not improving with Kegels exercises. Urgency is a factor which is more related to radiation therapy or underlying bladder problems, which can be managed with medications. Sexual dysfunction. In the Indian scenario, sexual dysfunction is one of the least talked and in various societies. The incidence of sexual dysfunction being reported to the clinician may vary from a metro city to a second-tier city to a third-tier city. Erectile dysfunction is the most common side effect of therapy for prostate cancer, which is more common after radical prostatectomy and over a period of time with radiotherapy also. A low libido may be seen in almost all patients with androgen deprivation therapy. Addressing these issues will definitely improve the quality of life for the patient, and especially in younger patients. The therapy or the treatment may begin with daily PDE5 inhibitors or nutraceuticals. If not, then we can shift to intracorporeal injections of Bimix or Trimix. And other vacuum erection devices have also been prescribed and shown to be effective. Very rarely, a patient also may ask or request for an implant. Bowel complications are more common after radical radiotherapy or curative radiotherapy to the bladder because of scattering of the radiations, even though in today's date, the complications have reduced and because of hypofractionation and more focused therapy. Radiation proctitis is more common after 5 to 10 years of radiation therapy. It is due to inflammation and irritation of the rectal mucosa causing discomfort and sometimes pain. Bleeding is also a common side effect, either urinary or rectal bleeding. And diarrhea is also one of the most common side effects following radiotherapy. Metabolic effects like weight gain, lipid changes in lipid levels in the body, and making it more prone to cardiovascular risk are more common after androgen deprivation therapy. Regular monitoring with liver function tests and lipid profile monitoring is essential in addressing these issues at the beginning. Psychological impact. One of the least talked issues in any cancer survivor in India is psychological impact. Given the large number of cancer survivors, more than 3 million men at present are living with prostate cancer. And as mentioned before, the active surveillance rates are increasing in low risk disease from 20% to 60%, and also in intermediate risk disease from 2.4% to approximately 13% in current date. So addressing various issues, especially in patients on active surveillance and in other cancer survivors also, is anxiety, depression, and cognitive changes. Cognitive changes more common in patients who are on androgen deprivation therapy. Patient can be sent for regular checkups or regular exercises, activities which keep the cognition intact. And if required, maybe the patient can be put on intermittent androgen deprivation therapy, which has lesser incidence of cognitive side effects. Essential lifestyle modifications, which are also mentioned before, are exercise, Mediterranean diet, and weight control. With that, I would like to conclude my talk. Thank you.
Excellent.
Thank you.
Excellent conclusion. Ravi Mohan, quick remarks. After that, we'll conclude after Deepak remarks also. Ravi Mohan, please.
Sir, excellent talk. The last talk probably is the most important aspect of management of metastatic prostate cancer, which and even the localized prostate cancer, especially the side effect part, which in itself is a huge topic and which should be one of the focuses of all the meetings because that's where we lack the knowledge. Rest all parameters almost standardized. I honestly want to congratulate. Chandramohan sir for this kind of belief that he has entrusted upon the junior colleagues to design such a program and the junior not junior I mean they done such a masterly presentations and job that it's very heartwarming and nice to see. In fact, I got educated myself by a lot of the talks which were given. Thank you, Chandramohan sir, for this opportunity as well.
Thank you, Ravi Mohan. Excellent. What you said is correct. Deepak, you want to say a few words?
Sir, like some of the messages in the chat box, like Ravi Mohan sir, like you could answer, like what are the treatment option in metastatic HSPC for liver and renal function deranged patients?
So I think the ADT still remains the standard of care. Enzalutamide would score over abiraterone in liver dysfunction. For renal dysfunction, either of them should be okay. Otherwise, ADT would remain the standard of care for all the irrespective of the dysfunction part.
How do you manage the hot flushes in the ADT?
Good question.
ADT therapy.
So Manas, I think you would be the person to answer that.
Hot flushes in the ADT.
In our practice, let me just phrase it that we typically want to avoid that question. Honestly, we won't explain the patient. We try to beat around it. We'll try to convince him, no, it doesn't matter and things like blah blah blah. Very rarely that you would have a patient who is so much bothered that you offer them medroxyprogesterone. But honestly speaking, we tend to beat around the bush. So answer it, Manas, for you.
Sir, sexual dysfunction.
Hot flushes.
Hot flushes.
Hot flushes.
On ADT.
Sir, hot flushes on ADT. Suppose a patient we obviously try to divert the topic as sir said. We try to ask them to try and focus on regular exercise and keeping themselves healthy, keeping themselves busy throughout the day. One of my colleagues' grandfather had similar hot flushes, who used to use a hand fan for wherever he would go and keep himself under AC environment. But even then, patients are usually bothered. Sometimes we tend to stop the ADT for a while, depending on the PSA levels, and try and maintain them for a longer time without ADT and for a short duration of ADT.
Thank you.
That's the clinical.
So, with all your permission, I'll give conclusion remarks. First of all, I thank Ravi Mohan for being an expert panel. Instantly, when the topic is planned, I made my mind. I know his capabilities, knowledge, commitment towards the science, and he's from the PGI, is professor, is interested in uro-oncology. Way back, now it is nearly 15-20 years back, he was a surgery PG when I was doing MCH urology. Since then, we go each other in the WhatsApp groups. We can understand how much dedicated these teachers at the institutions. We must respect them, and this valuable time is of very important for us. And I highly appreciate entire time you are there and you actively participated. Coming to Deepak, when I told it's my, if at all any credit to goes to me, selecting Deepak as the convener along with me. So he selected all the people, only one or two I suggested. Rest of all the people he selected, he has given without bias, and all of them, particularly everybody like Mithun PSA interpretation, very crisp to start with, early good start, very crisp points he told. Vishnu Prasad MRI prostate pyrites, good scientific presentation he has given. Deepak prostate biopsy, trust versus TP. It was like a debate, but he has given a lot of information. No bias on that. Sepuri Balaraviteja has covered the topic very decently. Amresh Mohan, crisp talk, a really crisp talk, very, very good. But 2 topics are given to him. Thoda 1 minute it is delayed, fine. Mujiban sir is senior, he is the only senior I have given. I was doubtful that he may get carried away because he is expressive, but his slides were also, as Ravi pictorial, very beautiful slides, very attractive to the eyes. And Tanmay, I don't have any doubt that he will do well because I know him for last 2 years. Oh, too good a person, my God. Hemnath with me only. I was also worried with this. He is really into the robotic surgery and is very knowledgeable person. Since long time, I'm thinking that let him be given chance. But he proved that he has good knowledge. He's very knowledgeable. He works with me, very simple person. And Ravi Chandar in the end, very smart and very intelligently has put all the literature and made it at the end exciting. Manas, you are on to the point, and especially as Ravi Mohan told, this is very important point. Still, I feel that 175 was the highest attendance, 110 was the average attendance. Now also to listen my conclusion, 58 people are there. So it gives kick for me that the next topic we are doing is private practitioners problems by juniors. Probably in the new year, Wednesday on 7th January, we are discussing about private practitioners problems. And also I request all of you, please for August next year, we are doing in Mangaluru, our ASU annual conference. We will have all these people somewhere are there involved in the annual conference. Thank you once again, ASU, for giving us this opportunity. Thank you.
Thank you, Chandramohan sir, for selecting as a convener. Thank you very much. And all speakers had an excellent talk. And thank you, Ravi Mohan sir, for being there for 2.5 hours continuously.
Great. Really great.
Completing your OT and being at home, utilizing your personal time. Thank you very much.
Really appreciate it.
Very knowledgeable.
Thank you very much.
Thank you, sir.
Okay,
Thank you, sir.
we'll conclude. Thank you.
Thank you so much, sir, for everything.
Yeah.
Thank you.
Thank you, sir. Thank you. Thank you, sir.